This is Soundcheck, your go-to podcast for ultrasound quality assurance, image review, and clinical education from MedStar emergency physicians. We walk through real cases, highlight what to look for, and dig into how ultrasound guides decision-making. Here's your host, Dr. Jon Watson.
Hey everybody, welcome back to Soundcheck, the monthly ultrasound quality assurance and education podcast from the MedStar Emergency Physicians ultrasound team. I'm Jon Watson, and in each episode, one of our stellar emergency medicine residents co-hosts to run through high-yield QA cases with practical takeaways you can use on your next shift. This month, we start in the neck with the internal jugular DVT, a great reminder that bedside ultrasound can confirm the diagnosis fast when compressibility is lost and color Doppler flow is diminished. Then we move to a patient with dyspnea and edema, where the echo, IVC, and lung ultrasound all point toward acute decompensated heart failure. And we use measurements like EPSS and fractional shortening to quickly quantify severe LV dysfunction. After that, we're going to review a first-trimester pregnancy scan where the crown rump length and absent cardiac activity are diagnostic for a missed abortion, and we talk through the key thresholds and management options. Next, we have a trauma case at a non-trauma center where a fast exam is positive in multiple windows and drives rapid transfer, even with initially stable vital signs. And then we finish with a painful erythematous antecubital fossa after a recent IV, where ultrasound reveals a non-compressible superficial vein consistent with superficial thrombophlebitis. And stick around for after the cases because we've got a great listener question on bowel ultrasound, how to recognize small bowel obstruction at the bedside, what measurements matter, and what dynamic signs to look for as you scan. As always, this is just an educational discussion and not specific medical advice. But let's go ahead and bring in our co-host for this month, Dr. Brzezynski. All right, so I'm here today with Victoria Brzezynski, who's one of our first-year emergency medicine residents. Victoria, thanks for joining me for QA today.
Yeah, thanks for having me.
Of course, yeah, let's get into some of these cases. First case is a older woman who came in to the emergency department because she had an outpatient CT done that had showed a concern for possible clot within her IJ. Her medical history was notable for that she had endometrial cancer and was undergoing treatment, and I think the CT was just a general screening CT that was done. So in the ED, they put on a probe and tried to find this diagnosis. So can you walk us through what you're seeing here, what the anatomy is? I'll give you a hint. It's not labeled, but this is the neck, the lateral neck that they're looking at.
Yeah, so we see the internal jugular vein at the top of the screen, which is the much larger anechoic vessel. And then underneath of it, we see the carotid artery.
Right. Good. So this is the same view, right? You look for when you're trying to do a central line in the IJ, but is this one that you want to put a central line in?
No.
Probably not. Yeah. Yeah. Why is that?
It looks like there's a big clot or some sort of irregular hypoechoic structure on the inside.
Right. Yeah, exactly. There's this big structure here. Let's pause it so you can see what we're talking about here. This big hypoechoic irregular blob within the IJ. Mm-hmm. And I think what they're trying to do as well is when they're trying to compress it as well. So when you're assessing for something like a DVT or clot, you want to assess for compressibility because the absence of that normal compressibility is concerning for DVT. Mm-hmm. So when they're compressing, you see that it doesn't wink at you, right? Mm-hmm. Usually the IJ should completely collapse. And that's one of the steps that you do when you do a central line, right, is collapse it and make sure that you're looking at the vein instead of the artery. Mm-hmm. All right, so let's go on to the next one. I think here they're trying to show the same, that they have this clot that not able to compress. Okay, so some of the other incidental things that we see in this view, this is obviously a very cool image. We can see the carotid artery down. You see these shadows that are coming off of the carotid artery here. Mm-hmm. And so saw a little bit coming off of the IJ here, a little bit of shadow. Mm-hmm. Have you seen that before?
It looks like edge artifact.
Yeah, so it's edge artifact. Yeah, whenever there's a fluid-filled structure, you see this a lot with the gallbladder too, when you have, which can confuse you and make you think you have a gallbladder stone sometimes. When you have a curved anechoic structure, sometimes you see this edge artifact of, looks like a shadow coming down, but that's just a normal ultrasound artifact to look out for.
Okay.
And then what does it look like they're doing here?
It looks like they're in longitudinal view.
Mm-hmm.
So you still see the internal jugular vein up top and then the carotid artery below. But
Yep.
you see how big the clot is.
Yeah. Yeah, it's not like measured in this one, but we can sort of assess if we go to our depth marker. So on the right here, obviously, is where your depth notches are. So we're at 3 centimeters of depth right now, so it makes it that each one of this distance here is about 1 centimeter. So it's about probably 1 to 1.5 centimeters in this dimension, and probably 2 to 3 in the other dimension. So this is not an insignificant clot. All right, and then walk us through some of the things that they're doing here, some other testing.
So it looks like they put Doppler on so you can see the direction of flow, and the blue color means that the flow is going away from the probe, and that the red color means it's going toward the probe.
Right, and you don't see flow in all the IJ, right?
Do not, yeah. Right. So it looks like the clot is blocking about half of that flow.
Yeah. So this is not a completely occlusive clot, right? That would probably be a lot more symptomatic if it was completely occlusive, because there's a lot of blood that drains through the IJ from the head. Sometimes you can see a lot of facial fullness and things like that if it's completely occluded. But she was asymptomatic, probably because there's some flow that's still getting through here. They do have the Doppler gate on as well, but it's not activated. It's not listening, in other words. But what you would usually see if you do have the Doppler gate on, and this is where you get the sound that comes out, is probably if it's on this area here, a venous waveform. So it's like more continuous rather than pulsatile. If you put it here, you'd probably see a up and down pulsatile pattern for your waveform. And then a couple of pictures here they're doing is just measuring it, I think, in the normal non-compressed state, and then when they're trying to do compression. This is not like a standard measurement or anything. I think it was just trying to see kind of how big the clot was and things like that. But let's talk about the upper extremity DVT a little bit. So what are some of the risk factors for why people develop these?
So it can happen in patients who are hypercoagulable, so those with cancer, and it's especially common if they have PICC lines or catheters or dialysis access or some sort of injury to that vessel.
Right. Yeah, because then it forms some sort of endothelial injury, right? Which is one of the things of the Virchow's triad, which, do you remember the other ones? Hypercoagulable,
and then slow flow.
Slow flow. So that's completes the triad there. Can these embolize?
They can. So it can cause PE, but it's a much lower chance than like a lower extremity DVT.
Yeah. So I think that's right, but you'd still treat them as the same with anticoagulation. So this is probably what's called a secondary DVT, right? So that there's some sort of cause for why she's got it. So either she actually didn't have a catheter, but catheters are very common, secondary cause, and some sort of other indwelling device, like sometimes a pacemaker, things like that, can also in the great veins of the head or neck, and malignancy in her case. But you can also get this primary upper extremity DVT, which, we think primary upper extremity DVT is pretty rare because they usually have to have some sort of risk factor for it. But there's this syndrome called Paget-Schroeder disease. I may not be saying that right, but it's also called effort thrombosis, when people are doing a lot of repetitive motions of their arm. So it's been described in a couple cases of like violin players that are practicing a lot for a big thing where they have their arm in sort of a weird position and then moving it a lot. That creates, it's thought to be this endovascular injury pattern as well that increases the risk for having a clot there. All right, so this is the IJ, right? What other arteries or veins in the head and neck would you be concerned about for DVT?
The subclavian vein and then the axillary or brachial veins.
Yeah, so those are the deep veins of the arm, basically. So you can then track your probe down. If you're concerned if they're having arm swelling and the IJ looks normal, you can look at the subclavian vein by putting your probe in the supraclavicular fossa and aiming down. You can visualize the subclavian artery and vein there, and then if you track out through the axilla, you can also see the axillary vein and artery. And you do the same thing, just putting compression down, and if it doesn't collapse, then you'd be concerned there's a clot there. And it's not always this clear. Like sometimes you can't see the clot. This is very obvious that you can see it, but a lot of times just the absence of that compressibility is helpful. or is diagnostic. And then it's also helpful to put on that Doppler gate as well, because if you don't have that normal venous waveform, then you know that there's a clot in there too.
Okay.
So she was asymptomatic in this case, right? But what are some of the signs that you could see if you're concerned about that would make you concerned for a DVT?
Having unilateral arm swelling, or neck or facial swelling, seeing the veins puff up on the chest wall.
Yeah.
If they have like a recent catheter or a cancer diagnosis as well.
So some sort of risk factor. And perfect. So we mentioned that you would usually manage these the same, right? Similar to a lower extremity DVT, which is a lot more common. And you don't always have to remove the catheter, right? This is probably something that you're going to discuss with one of the consultants, whether or not it's a dialysis catheter or something used for chemotherapy or whatever, but don't always have to remove the catheter, except if it's non-functional or if it's infected. Usually you would need to anticoagulate for at least 3 to 6 months, have them follow up with vascular or hematology. And what are some of the other complications that you can get from this? What would you be worried about developing?
SVC syndrome, phlegmasia, PE, and then also could just affect the catheter that's in place.
Yeah, and phlegmasia, remind the listeners that you can have kind of a couple variants where you have the Alba or Dolan's, a white or blue version, but it's basically when you develop arterial insufficiency to the leg, or to the arm, and you would develop limb ischemia. All right, so this was overall just basically a confirmation study, but shows you that this bedside ultrasound can be very quick and easy to diagnose in upper extremity DVT. So this is a male who came to the emergency department with lower extremity swelling and had dyspnea on exertion. So the clinicians did multiple studies, including a echo and a thoracic lung exam and IVC exam. So let's walk through each one of those. Let's go through the echo first. So what view is this, and how do you usually obtain this?
This one is parasternal long, and for this one you'll have the probe marker face towards the right shoulder.
Yep, probably about like the third or fourth intercostal space, just lateral to the sternum on the left side of the chest. And let's remind people of some of the anatomy here. So we have up here the left atrium, we have the mitral valve, we have the left ventricular cavity here outlined right there. So this is all the myocardium. The bright white surrounding it is the pericardium. This is the descending thoracic aorta. And then here we have the right side of the heart. This is the right ventricle. In this view, we can't really see the right atrium very well. We can see that in other views. And then here you see the aortic valve. So the blood's coming through the left ventricle and up through this aortic valve and the left ventricular outflow tract. So just looking at the heart, what do you see? What do you think about the ejection fraction?
It looks like it's pretty low. First off, you can barely see the left ventricle contracting, and also the mitral valve. When it's fully open, it's nowhere near the septum.
Yeah, you can sort of just, by looking at a lot of normals, you see that the heart is way less contractile than a normal state, and the walls of the left ventricle are really not coming together like they should. So this is concerning for a decreased ejection fraction. And then you mentioned the mitral valve. So there's a couple ways that we'll go through how to assess the ejection fraction. One of those is the EPSS, looking at the motion of the mitral valve. So they did this in this case. And here they created a M-mode tracing with the cursor right over the distal end of that mitral valve. So they probably put it right here. And they're trying to assess the distance between the interventricular septum, which is this kind of bolded line right here that doesn't move that much because it's hypokinetic, and the E point, which is this first peak that you have of the mitral valve tracing. So then they measure this distance, and we get 20.5 millimeters or 2.05 centimeters. So how do you interpret that number?
So anything over 14 is a severe reduction in EF. So his is pretty severe, but less than 7 is normal.
Right. And then if you have something in the mid-range between 7 and 14, that'd be usually in the moderate reduced bucket. So that's definitely decreased. So let's go through a couple other views here. Now they have parasternal short, so they're rotating the probe in the ED echo standard towards the right hip now. And then you have the left ventricle cavity here. And then the right ventricle, not super well seen in this one. They're going to try to optimize their image, but this is the RV right here. So let's see, I think they crisp it up a little bit. And then we could see the level, we're at the level of the papillary muscles. See these irregular growths off the side. These are basically the papillary muscles that are holding the chordae tendineae. You see any signs there may be right heart strain or anything, or what could you look for in this view?
I don't see any on this patient, but you would see D sign.
Yep.
So the right ventricle impeding onto the septum.
Yeah. So sometimes when the right ventricle, which is over here, which is not that prominent in this view, which is normal, right? Because it's a lower pressure than the left ventricle. But if it's has strain on it or high pressure, it will exert its pressure onto this interventricular septum right here and then push it over. Then you have a shape of a D. So this would be flat here, and then it'd still be curved in this free wall. And that's the D sign, which is not seen in this case. So now this is another view, another way that we can assess for ejection fraction, another objective or quantitative measurement, which is called the fractional shortening. So now we're taking the end diastolic diameter of the LV and the end systolic diameter, and we're calculating basically a percentage change between those, and then that the machine will give you a spit out of the estimated ejection fraction based on that. So we can see here that we're getting a EF of about 28%, but they are getting that through this M mode tracing. So they're putting M mode basically right through the center of the LV, which is here. And then they're going to calculate the widest area, which is this one, minus the most narrow area. And you see there's not really that much of a change just because the LV's not moving that much. But in normal heart, with a normal EF, you'd see more of like a pretty prominent sine wave pattern. And then it gives you this ejection fraction of 28%, which is consistent with what our qualitative assessment was, just looking at it grossly, and what we saw with the EPSS. So then now we're going to apical 4. Now we have the left ventricle, left side of the heart over here. Right ventricle and right atrium, not super well seen, not the best image. This is one of the harder views of the echo to get. Same thing here. It's not a super great view, but we have a lot of the information from other views as well that we can use. Same thing with the subxiphoid. What do you think about this one?
It looks like there's a mild pericardial effusion.
Yeah, there's maybe up here, there's a little bit of mild pericardial effusion. Overall, the image is not that great quality, so they try to crisp it up a little bit. Sometimes it can be helpful to have the patient take a really deep breath in when you're struggling with the subxiphoid, or make sure that they're laid down completely flat. But taking a deep breath in will contract the diaphragm, and the heart's kind of sitting right on top of the diaphragm, and will move down more towards their feet and closer to the surface of your probe. So you sometimes get a better image with doing that. I think they probably did some maneuver, because now you can see the heart chamber is outlined a little bit more clearly. And you see this trace effusion, like you mentioned, anteriorly, but probably not really that hemodynamically significant. I don't see any findings of tamponade, which won't go through extensively, but this is pretty minimal here. All right, IVC. So now they are using the probe, but have the indicator up towards the patient's head. So now we're looking at more of a longitudinal view, right? So the head's up here, feet down here, and we have the IVC in long axis. So what do you see on this IVC here? What are you noticing?
We see it go into the right atrium, and then it's not fully collapsing. I wouldn't say it's at least 50% collapsing.
And then what's this thing coming out here? This is kind of prominent in this view too.
Hepatic vein.
Yeah, hepatic vein. So that's important, because that's a landmark of where you're going to do the measurement of the diameter. So you mentioned that IVC kind of looks big. It doesn't have that much respiratory variation to it. But if you're going to
put a measurement to it, usually the area is about 1 centimeter distal to where that hepatic vein was. So that was about right here. And they measure about 1 centimeter down and then take that cross-sectional diameter right there. And we're getting 2.6, which is considered abnormal. The cutoff's usually 2.1. So if you have greater than 2.1 and less than 50% variation, that's concerning for elevated right heart pressures. So I think that he probably does have a elevated right heart pressure, or right atrial pressure specifically. All right, let's move on to the lungs. So they changed the technique. The footprint of the probe looks different right here. So what'd they do?
Looks like they used a linear probe.
Yeah, linear probe. The pleural line is very superficial, right? And you usually don't need a ton of depth. So using linear probe will sometimes get you more crisp images, but you can use the linear or the curvilinear or the phased array probe to look at the lungs. So does this look normal or abnormal?
It looks abnormal, so I'm seeing more than 3 B lines per intercostal space.
What's the B line?
It's concerning or a B line is just like a vertical big shooting star, I guess I feel like is what I call it.
Or comet tail artifact, So these bright light white lines that originate at the pleural line and then shoot all the way down to the bottom. And you mentioned 3.
Yes, so that's concerning for pulmonary edema.
Yeah. So sometimes you can have like a scattered, just like 1 B line or something like that, and it may just be a normal variant, but you're seeing definitely more than 3 in this view. And then if you're concerned for pulmonary edema, is it usually just like in one space like this, or you see it all over?
Probably all over.
Yeah, because that's a diffuse process, right? So you have edema in all of the lung fields mostly. So in order to diagnose pulmonary edema, it should be in more than one lung field, because sometimes you could have B lines as a consequence of pneumonia, just if it's focal there.
Yeah.
So they're going to go through a few areas. We see that good lung sliding and these big, bright comet tail artifacts or B lines that you're noticing. We're going to go to the base of the lungs, and they switch back to the curvilinear probe for this one. Because just sometimes you need a little bit more depth. What are you noticing here?
Oh, it looks like there's a pleural effusion because we see some anechoic fluid collection above the diaphragm.
Right. Yeah. So this right here is the pleura, and you can see the lung sliding a little bit here. But then underneath that, or adjacent to it, you see the diaphragm. So we can separate this from intraperitoneal fluid, right? We know this is thoracic because this is up towards the head here, and this is above the diaphragm. So we have this anechoic fluid collection going down, and then I think we see it here as well. And then just to point out, you see some artifact here as well. This is called a refraction artifact, but you could see a refraction artifact when you have a curved hyperechoic structure that sometimes repeats and just confuses the ultrasound because of the way that the sound waves bounce back. So you see this other repeating pattern down here, which is just an ultrasound artifact. And then this looks like it's bilateral too, right? Now we're in the left base, spleen here, and then the same thing. You notice that you have a anechoic fluid collection above the spleen in the thoracic cavity. So what do you think about the patient based on this ultrasound, about his fluid status and what the potential diagnosis would be?
He definitely looks fluid overloaded.
So it looks like he's having CHF for sure. And what's interesting about this is that the chest x-ray was normal in his case. So ultrasound can actually be more sensitive in the early stages if you just develop this before the x-ray findings become apparent. So one more pro for ultrasound, basically. Yeah.
This patient was a G1P0 female. She underwent intrauterine implantation with a previously confirmed IUP, and her estimated gestational age was 8 weeks and 2 days. But she was presenting with some cramping and vaginal bleeding.
Okay, so they do an ultrasound to check the pregnancy. So what do you see?
We see the uterus, and we do see a fetus inside, but I do believe we do not see a fetal heart tone on this patient.
Yeah, at least not in this first view. So we're going to go through a couple. And not really much activity. Sometimes you can see it moving around just a little bit in this size, but definitely see fetus in the uterus there. I'll just scan through in a couple ways here. Okay, so the M mode here is not activated, right? Because you don't see any M mode tracing, but you can tell what they're trying to do is find the fetal heart rate to be able to get the fetal heart rate measurement. But as we're scanning through, like you noted, the head's up here, right? So the heart would probably be in this midsection right about here. But we don't see really any flicker. So this would be, unfortunately, I think, concerning that the fetus may have had undergone intrauterine fetal demise. It can be confusing sometimes in early pregnancy when you don't see a heart rate. And when do you know that you should see a heart rate?
When, at least on transvaginal ultrasound, the crown rump length measures greater than 7 millimeters.
Right, yeah, because sometimes it's just that the fetus is too undeveloped. You see something in there and you can't see a fetal heart rate. Doesn't mean necessarily the pregnancy has failed or that there's a missed abortion, but that it's just too young to develop. But this one looks like it's developed enough that it should have fetal heart rate by now. The measurement is 8 weeks and 6 days, which is consistent with the dates that she had told us of an implantation date of 8 weeks and 2 days prior. And the crown rump length here is measuring 22 millimeters. So you mentioned 7, so that would be, this is 3 times the size. So unfortunately, this is a diagnostic of a missed abortion. So let's go through the ovary here too, just make sure, we usually do this as routine part of scanning, and look, we can't really actually see the ovary in a lot of transabdominal imaging, but we're just looking for the absence of something abnormal, right? We see these things here. These are the iliac vein and artery, but we're just making sure that we don't see a big adnexal mass. So why potentially in her case, I don't think in her case specifically because she had IUI that she'd be at risk for this, but what about other people that are on pro-fertility agents or IVF? What would you be concerned about?
So those who are on IVF, they have an increased risk of a heterotopic pregnancy, so having both intrauterine pregnancy and then another pregnancy somewhere else in the body.
Right.
But in this patient, we're just checking her ovaries to make sure.
So most patients that are not undergoing IVF or on some sort of pro-fertility drug like Clomid or Clomiphene, they typically, if you diagnose an intrauterine pregnancy, that's enough to really exclude a heterotopic, but you just need to be worried in people that are on some of those drugs or they're at higher risk for having heterotopic, so make sure you check that nexa for both of those. In her case, she was seen by OBGYN and underwent a DNC, but what are some of the other management options that you can do for a missed abortion like this?
So you could take misoprostol, and it can sometimes be combined with mifepristone as well.
Yeah, and that usually helps contract the uterus and ripen the cervix and to allow for delivery of the products of conception. The other thing is you can do nothing. You can just do expected management, and that's reasonable as well. But sometimes you have it can be several days, and you just make sure that the patient has close follow-up and that the contents are completely evacuated eventually, because this can become septic, and you can have a septic abortion. So here's missed abortion. There's other different types. So what other have you heard of?
There's a threatened abortion, and then there's also incomplete abortions.
Yeah, so threatened we see a lot, right? That's like any patient with vaginal bleeding that comes in with a intrauterine pregnancy with a heartbeat. It's just that they're at risk for having miscarriage, but a lot of them do end up going to term and don't have any complications, but that does increase your risk for having miscarriage, having first trimester bleeding. And then the second one you said was?
Incomplete abortion.
What's that?
When you've had partial passage of products of conception, but the ultrasound still shows there's some retained tissue inside.
Right. And then that you can sort of manage the same way as this. You can do drugs. That's most commonly done, or sometimes surgical management as well if you can do dilation curettage or vacuum-assisted aspiration. This next case was a gentleman who came to the Georgetown Emergency Department, and for those not in the MedStar system, is a non-trauma center that had a head-on MVC and presented with stable vitals, but was brought into the room and a fast exam was done for setting of trauma. So, Victoria, can you walk us through the fast exam and what views we're looking at here?
Yes, so we look at least 4 different views. So we look in the right upper quadrant, the left upper quadrant, the bladder, and then a subxiphoid cardiac view. So first you have a right upper quadrant here, and we see free fluid underneath the liver, so in Morrison's pouch.
Yep. So the liver, between the liver and the kidney here, in Morris's pouch. Where else?
Also at the liver tip.
Yep.
And then above the liver as well, below the diaphragm.
Perfect. Yeah. So these are all the areas. See, the liver tip is one of the more sensitive areas to look for. So you make sure you get that as well. And then you have some subdiaphragmatic fluid here that you noted. So that's definitely a positive red quadrant view. Let's keep looking through their images. It's good quality images here.
Yeah. And then now we're in the left upper quadrant, and there's a little bit of free fluid above, I think, the spleen here.
Yep. So this is the spleen right here. And then you have some fluid here that's basically subdiaphragmatic or around the spleen and around the spleen capsule too. So 2 views positive. Here's another view of that free fluid, beginning of the clip here. All right, this is around the spleen tip you're seeing. And now let's look at the bladder as well.
Bladder, there's a little bit inferior to the bladder.
Yep.
Or I guess it would be posterior
Deep,
to the bladder. Yeah.
So let's do a bit here. So this is the bladder outline, right? It can be confusing sometimes when you have free fluid in the pelvis because there's a lot of loops of Bowel and things like that, but this is the bladder. And then you have here in the rectovesical pouch, you have this free fluid here as well. So 3 out of 4 views positive. And then
And the last one is just the subxiphoid, which does not show a pericardial effusion.
right. All right, so lucky for him, no pericardial effusion, but a lot of potential hemoperitoneum, right? We can't say that it's blood per se, right, in a fast exam, but we say there's free fluid there because the echo texture of blood and ascites and urine, this could be a bladder rupture, right, and this can cause this intraperitoneal free fluid, but it would be concerning for hemoperitoneum for sure. So now it looks like they're doing it extended fast. So what's going on here now?
So now they're looking at the lungs, and it looks like they placed it at mode on, and we see the waves on the beach sign, and which shows that there's no pneumothorax.
Right. So this is a kind of a visual way that you can show the lung sliding, right? Of course, you can record a clip of the lung sliding like this, right? And you can see that back and forth motion, and it kind of has that quivery appearance to it. People say like ants on a log sometimes with ants walking across there, but that's normal lung sliding. And the seashore sign or waves on the beach sign is indicative of lung sliding. If you did have a pneumothorax, what might you expect in this pattern here?
You would see the barcode and no like sand.
Yeah, the barcode sign. So you see that there's a change in the pattern, right? That it looks more, this is what motion of the pleural line looks like down here, but the soft tissues and the skin is not really moving. So you'd see this pattern here repeating all the way down towards the bottom of the screen. That's called stratosphere sign or the barcode sign. So in this case, he definitely had a positive fast. What's remarkable, I think, about this one is that first off, I mentioned that he went to a non-trauma center, right? Which happens, of course. And this was diagnosed within 10 minutes of him hitting the door, right? So the clinicians knew this patient was sick, even though his vital signs, fortunately, were compensating and he wasn't showing signs of shock or anything yet. But this means that this is obviously a surgical emergency and needs to go to a trauma center. So after they got these images, they were able to get on the phone with the transferring center. Of course, they still did do a CT scan while they were waiting for transfer, but it wouldn't be required, right? Because you know the diagnosis and the patient needs an XLAP. But a lot of surgeons will like to know, especially in a stable patient, which he was, where exactly the injury was. And he had a splenic laceration, which caused all this hemoperitoneum, but ultimately was transferred very, very quickly due to this fast, and he had a great outcome. Last case came to the ER because she had been hospitalized 1 week prior and had a IV placed in her left antecubital fossa. And basically since discharge, she was saying that she's been having pain and erythema surrounding in her left AC. So she went to an urgent care and they put her on an antibiotic thinking it was cellulitis, and she didn't really have much improvement, so she came back down to the emergency department for reevaluation. So can you describe some of the findings you're seeing here in the left antecubital fossa? They're using the linear probe. They have it on superficial setting.
We see some soft tissue edema at the very top of the screen.
Yeah, so the first half centimeter or so, based on our depth marker here, we see this almost like cobblestoning, right? It's not super classic cobblestoning, but we see edema, this hypoechoic and anechoic stuff here within the skin. This is not normal.
We see a superficial vein.
Yep, so there's a vein here. And usually, I'll tell you, when I'm reading about this case, they were trying to use graded compression, just like we do with a DVT study, right? Mm-hmm. So they're pushing down what should be happening to the vein typically.
It should be compressing, but it's not.
Yeah. Especially these really superficial ones, like these are the ones you do peripheral IVs and stuff like that, that they should collapse very, very easily. Mm-hmm. And then we see kind of this rim as well, this hyperechoic rim kind of within it that just doesn't look like a normal vein. You can see actually some other vessels. I'm not sure if they're artery or vein down here, but you don't see that kind of internal echoes that you do in these down here. So you'd be concerned somewhat that you have a clot there, right? Mm-hmm. So that's a known complication sometimes of having IVs. Right now they're putting on a Doppler box here, and we don't really see any flow, right? You see flow within these vessels down here and an occluded superficial vein. Mm-hmm. So this is called what?
Thrombophlebitis.
Yeah, superficial thrombophlebitis, right? Mm-hmm. So it's different than a DVT, kind of similar in the pathophysiology of it, right? We talked about in that first case about the Birchall's triad and the hypercoagulable state, which she may have had because she had a recent stroke, some sort of endovascular or endothelial injury, right? Probably from having peripheral IV, and maybe some stasis is the other item in the triad, but that puts you at risk for having this superficial thrombophlebitis. So how do you usually treat that?
So you would use warm compresses and NSAIDs.
Yeah. In her case, they did continue the antibiotics because the picture of it in the chart, it does look pretty red, and she did have some drainage from it. They were looking primarily to see if there's an abscess because she said that there was some pus coming out of it. So they did continue that because there is these soft tissue changes. But I think it probably wasn't resolving completely because there was still an underlying superficial thrombophlebitis that just needed some time and heat, like you said, and NSAIDs to help improve. All right, so she didn't have any history of cancer, but any associations you have heard of with cancer for superficial thrombophlebitis?
So it can be Trousseau syndrome, which occurs or can occur with some other malignancies, usually pancreatic or GI, but it's when you're having like more than one superficial thrombophlebitis.
Yeah, so you'd be concerned about that. And patient comes in 1 week and they have one in their leg and then they have one in their arm. It could be a perineoplastic syndrome, just to be on the lookout for, but this is a pretty classic case where they have an IV placed and they have superficial thrombophlebitis. It's just one episode. Victoria, we saw a lot of interesting cases. Can you give the listeners maybe one pearl per patient that we reviewed today?
So for the first case, when we went over the IJ DVT, basically if you can't fully compress the IJ and there's loss of a Doppler signal, then you've pretty much made the diagnosis of an upper extremity DVT at the bedside. For the second case, for heart failure, you can use EPSS, and if it's over 14 millimeters, it's one of the fastest bedside ways to recognize severe LV systolic dysfunction without having to calculate anything. And then the third case of a missed abortion, if the embryo measures over 7 millimeters and it has no cardiac activity, then that is a missed abortion. For the fourth case, for a trauma fast, if the fast is positive, it can be meaningful even in normotensive patients because it rules in hemoperitoneum and should immediately trigger trauma transfer decisions. And then in the fifth case of superficial thrombophlebitis, a superficial vein that won't compress on ultrasound and contains a clot is superficial thrombophlebitis, not cellulitis, and that can occur especially in someone who had a recent IV.
All right, Victoria, let's go and take a listener question now. We actually have a question from one of our attendings about bowel ultrasound. Let's take a listen.
Hey, John. Great cases. My question is, how do you tell for bowel obstruction, and what signs are we looking for in terms of dilation of the bowel, like measurements or any findings that you might see on ultrasound? Thanks.
That's a great question. Bowel ultrasound is not commonly done, but can be used to diagnose small bowel obstruction fairly quickly and easily at the bedside. So typically when you're scanning through someone's abdomen, you don't really see that many bowel loops because they're usually decompressed and you just see a lot of the bowel gas and scattering and things like that. But when you do have a small bowel obstruction, it will be pretty remarkable. There's no specific protocol that I usually use to do it. I just will take a look in all 4 quadrants of the abdomen and usually would use the curvilinear probe. And I'll show you a picture of one of the patients that I did recently that had a umbilical hernia and came in with abdominal pain and nausea, vomiting. So here you can see underneath the skin, you have this hernia sac labeled with this U here. So you can see you have one bowel loop going into the hernia sac and then one that's leaving the hernia sac here. This one looks pretty dilated, right? It's coming in and then you have this hernia and then kind of a decompressed, very small looking decompressed loop of bowel here. That's measuring less than 1 centimeter. So this is concerning possibly for a transition point of a small bowel obstruction. So let's look at the other bowels though to see what it would look like typically. So this is an example of what you may see when you're scanning through the different quadrants of the abdomen if you do have a small bowel obstruction. So this right here are the plicae circularis, and sometimes referred to as the keyboard sign. And usually you don't really see this normal anatomic structure when you have decompressed bowel. It just doesn't show up and you have a lot of gas and instead of fluid within the bowels. But here we have a loop of bowel that's very dilated, right? Greater than 3 centimeters, which is the diagnostic criteria. And the wall is thick as well. So the wall should be less than 3 millimeters. So this wall is measuring 5.5 millimeters and a lumen, the inner part of the wall to the inner part of the wall, measuring greater than 3 centimeters. So what can you see, Victoria, sometimes with the peristalsis?
Mm-hmm. With the SBOs, you can have to and fro peristalsis.
Right. So usually peristalsis is one direction, right? So I didn't capture it super well in this one, but what you would see is that in a normal non-obstructed bowel, right, everything goes from the mouth to the rectum. But in a obstruction, you would have the peristalsis going this way, and then it would go back. And then as the bowel's peristalsis, because it's meeting some sort of blockage, right, and it comes back. So that's called to and fro, kind of washes back and forth like that. Sometimes, though, in a situation where you have a really high-grade obstruction or you're developing ischemia, you can have absence of peristalsis. So that's also a notable finding, too, because the bowels just don't have the normal function to them and they just are not moving at all. That's usually later in the disease process. But here you can see, again, that keyboard sign, really dilated loops of bowel. Look through again here, see multiple, we measured it in different areas that looked pretty diffuse. And again, the umbilical hernia was the transition point where you saw dilated loop of bowel coming in and then the bowel getting basically obstructed here and causing all this proximal dilation and then the distal decompression. So this patient had a CT scan that confirmed a small bowel obstruction with the transition point in the umbilical hernia sac and underwent emergency surgery.
Well, that brings us to the end of this episode. So remember, if you'd like to record a question to be answered by one of our experts on this podcast, you can record your audio question at speakpipe.com/soundcheck. For more resources, you can visit our website, mepsano.com. And we are happy to announce that these episodes of Soundcheck now qualify for continuing education credit for physicians and PAs through the MedStar Cytel Center. See the description for the course number and links, or you can just search the Cytel catalog with the word Soundcheck for a list of all the episodes. I hope you enjoyed all the excellent teaching points from Dr. Brzezynski, and I hope that you'll join us again next month. So for now, take care and go out and put these pearls into practice.